cancers in my brain is obviously something nobody wants to certainly hear. Just going back historically now, 2012, some of us were there. CLEOPATRA gets presented. That's the addition of pertuzumab to the taxane and Herceptin, which was the standard at that time. And of course, we saw an increase in median progression-free survival. We saw an overall survival almost reaching 5 years. And can you talk to me a little bit about that regimen, walk me through it, and how you think that's really sort of changed the landscape over the last 10 years?
Yes, for sure. I remember being at that presentation and getting goosebumps and standing ovation, and things like that don't happen very often in breast oncology. And so certainly that was a pivotal time for us. And I think that's why it's even more exciting now that we're talking about the future and moving beyond that. But certainly at that time, CLEOPATRA established the standard of care with the addition of pertuzumab. So dual anti-HER2 therapy in combination with the taxane. We get a median progression-free survival of about 18.9 months with CLEOPATRA, which was basically a doubling from what was the standard of care without pertuzumab. So that really has been the mainstay of treatment for us over the past 10 years. And we all certainly have patients in our own practices that have done exceptionally well on that regimen. We also have patients that have not done quite as well. And so certainly we have opportunity to look for improvement.
And Mabel, can you touch on maybe some of those unmet needs with the CLEOPATRA regimen?
Yeah. So I think there's questions on both ends, as you mentioned. One is that about 16% of those patients continue on HP. And the idea is we have long-term survivors, dare we say, even cured patients. But is there an opportunity at all to stop any trastuzumab or pertuzumab-based therapy? I don't think any one of us are feeling comfortable that that's the case. The second opportunity is in those patients who we know, and it's around 15% of those patients who actually do not do well with the regimen and do progress early or through that regimen. I think those opportunities are there as well.
And I always think about, the blood-brain barrier, right?
Absolutely.
And the CNS, and a lot of these patients are going to recur in the CNS, and are there opportunities there? And can you talk about, obviously, the goal of moving sort of to an ADC, sort of non-chemotherapy? What were some of the challenges with the taxanes?
Certainly, I think what we see when we're using a CLEOPATRA-like regimen is standard taxane chemotherapy. Depending on whether these patients were treated in the curative setting, they may have residual toxicity. Persistent and maybe permanent neuropathy is kind of the one that seems to be dose limiting for us. Not to mention the impact on fatigue and quality of life, hair loss, things that really matter to patients that are continuing to try to live their life. So I think that's a huge thing. And I think the other thing that we really get concerned about in this population is, when patients recur, is how do they recur? Because if they recur in the brain, if they recur in the central nervous system, there's really nothing more life-altering for that patient population. You talk about whether they need whole brain or SRS or, whatever that looks like for them, it's really catastrophic in terms of their quality of life. Yeah, and it's a huge fear.
Yeah. Cancers in my brain is obviously something nobody wants to certainly hear.